This week we're going to focus on infection. So first off, what is an infection? An infection is going to occur when there is an invasion and multiplication of a microorganism within the body. An infection will only occur if that host is susceptible and is introduced to a pathogen that can cause the disease. There are some microorganisms, by the way, that are present at all times. And those we'll typically call a resident or a normal flora, which we'll talk about here in a few slides. So if someone has an infection, there are 4 different types of infections. First is bacteria that can cause an infection that would cause a bacterial infection. Bacteria are single-celled living organisms that can survive independently. They are so independent that they can even self-replicate. They don't need a host. They don't need anything. They can do it on their own. They are in size larger than a virus. Some examples of some bacterial infections are like strep throat, a UTI, MRSA. However, like I said earlier, there are some bacteria that are just a part of the normal flora and they're there to protect us. The treatment for bacterial infections are going to be your antibiotics. Then next you have viral infections, and those are from viruses. These are non-living infectious particles that require a host to reproduce. So bacteria do not require a host to reproduce, viral does. Viral infections, they are actually, the virus is typically smaller in size than bacteria is. Some examples are your common cold, HIVs, COVID-19, and influenza. The treatment for viral infections are going to be antivirals, not antibiotics. If you give somebody with a viral infection an antibiotic, it is not going to help them. In addition to antivirals, you will likely be doing supportive care and participating in prevention with those vaccines. Then next you have fungal infections. So these are a eukaryotic organism. So think of your yeasts and molds. These can either be unicellular or multicellular, but they really like to thrive in a warm, moist, dark environment. So some examples that you may encounter are like candidiasis, that could be oral thrush or vaginal yeast infection, tinea pedis, that is athlete's foot, and tinea corpus, that is going to be ringworm. Treatment for these, again, it will be an antifungal medication, whether it's a topical like cream or powder, or it's a systemic and oral medication. Again, for a fungi infection or a fungal infection, we are not to give an antibiotic or even an antiviral. That will not be beneficial. And then lastly, you have parasites. So these are organisms that live in or on a host and take nutrients from it. On the slide it says protozoa, that is a type of a parasite. And some examples of protozoa infections are like malaria, Giardias. Then you also have helminths, which are pinworms and tapeworms. And then you have ectoparasites, which are like lice and mites. So how do these parasites spread then? So they have to live on or in a host. So they can spread through contaminated food and water, soil, certain vectors like a mosquito, or even poor hygiene. Again, the treatment with this is going to be an anti-parasitic, or if it's a parasite, or an anti-helminthic medication for those specific parasites. So the next is going to be our chain of infection. The chain of infection is going to describe how an infectious disease spreads. So really, to prevent infection, we as nurses want to break any link within this chain. So it's a circular chain. If we break that link, then we can prevent that infection from spreading. So there are 6 links here. So first we have an infectious agent. So this is like the microorganism itself that causes the disease. So on here, it's the pathogen. Examples are, again, like we talked about on the previous slide, bacteria, viruses, fungi, parasites. So again, your parasites, possibly pinworm, fungi, a candida, viruses, influenza, bacteria, maybe a staph. So how can we break the link here at pathogen? This, for us as nurses, is going to be important when we do hand hygiene, we're disinfecting and sterilizing surfaces, and when appropriate, giving the correct antibiotic versus antiviral. That's going to be more on the physician side since they will be the ones ordering it. So then the second one of the chain is a reservoir. So this is where the organism lives, grows, and multiplies. Most commonly, this is going to be from a human, but some other examples are like animals, water, soil, surfaces, like such as equipment, and then food. So again, how do we as a nurse break this link? Making sure we provide and complete proper hygiene, that we have a clean environment, we are storing and handling food correctly, and same with medications, removing any standing water near the patient, and cleaning equipment after and between patient use. And then of course you then need a portal of exit. So how is it going to get out of that reservoir? So this is how the organism is going to leave the reservoir. Examples are commonly through like the respiratory tract of a human, which is coughing and sneezing. Maybe if that individual is having some GI upset, vomiting and stool, it can spread that way. Through blood, so through needles, needle sticks, wounds. Also with your GU tract, which would be your urine, and any type of skin break or damage. If that skin's not intact, that could be that potential portal of exit. So how can we break the link here? Making sure that we are educating our patients on masks if need be, cough etiquette, covering their wounds, if they are if they have like bodily fluids, making sure that they do know the safe disposal of that. That's going to come into play a lot with like your cancer medications. And then what's the proper handling of specimens? So making sure we do know how to appropriately send through the tube system a urine or stool sample, etc. Then next, the fourth step is that mode of transportation. So how is the organism traveling to the next person? So there's different types. We'll go into more depth throughout the slides, but most commonly it's through contact, whether it's direct or indirect, through droplets, which are large respiratory droplets, or airborne. These are even tinier droplets, essentially a particle that can stay suspended in the air. You have a vector, so that is like another living thing, so like a mosquito or tick, and then a vehicle. So the vehicle would be contaminated food or water. Again, it's important for us to provide and complete hand hygiene, utilize the appropriate PPE wear, following isolation precautions, cleaning and disinfecting all the surfaces, and handling food safely. And then you have the fifth step, which is the portal of entry. So this is how the organism is going to enter the new host. So this can be done through mucous membranes. Of course, if they're eating something, it's going to go through their mouth first. Any type of skin break. So if they have an IV site, any type of wounds, their respiratory tract and GI-GU tract. Again, how do we break this link? Always hand hygiene, that's going to be your number one. Maintaining skin integrity, utilizing aseptic techniques, making sure that we are doing sterile procedures when needed, especially with like our central lines. That would be important. Then also making sure we're utilizing the appropriate PPE. Number 6 is that person that pathogen just went into, they have to be susceptible. So that person is at risk for an infection. Some risk factors include age, either the very young or very elderly, chronic illness, immunosuppression, poor nutrition, stress, any breaks in the skin, any type of invasive device like an IV or Foley catheter, And then how, again, can we break this link? This is when we do vaccination or education on good nutrition and hydration, making sure they're getting plenty of rest, managing those chronic conditions that they have, and then infection prevention during procedures, and educating simply. So what are the modes of transmission? So these modes of transmissions, this is how the pathogen moves from one host to the other. So for us as nurses, we need to focus heavily on this because this is where we're stopping that transmission and essentially preventing an infection. So there's 5 main modes of transmission. The first one, most common, is going to be contact transmission. And so this is through direct contact first. So this is person to person, a physical contact is done. So this is if you are the nurse, you're touching a wound without gloves. And then you're going to another patient without washing hands. If you're bathing a patient, again, that's direct contact. If you're in a relationship with somebody, not as a nurse, but in your private life, and there's sexual contact between 2 individuals, that is a direct contact and a spread of that infection. Also, unsafe handling of contaminated body fluids for us as a nurse. So these such diseases that can be spread this way are MRSA, C. diff, scabies, and then in the opposite of direct is your indirect contact. So this is where a pathogen is transferred through an object. So through something else, it's not direct from person to person. So example is, say you touch that bed rail of somebody and there's a bacteria or a pathogen on that bed rail. Well, now you are indirectly coming into contact with that. Same with your phones, stethoscopes. That's why in your basic exam, it's very important that you most likely learn this in lab, but it also is going to be applied to when you go to the hospital, you do a basic or a focused assessment on somebody. Anytime you utilize that stethoscope, we're cleaning it before and after utilization. Also those keyboards, everyone's touching keyboards at the hospital or an outpatient clinic. And then those blood pressure cuffs. If you think about it, most people inpatient have their own blood pressure cuff, but in some settings you may have a communal or a shared blood pressure cuff. So making sure that we clean that. So us as nurses, making sure that we are cleaning that equipment again, not only our stethoscope, but any equipment that we're coming into contact with or that is shared between patients. Also making sure that we are doing proper hand hygiene before and after touching objects in a patient room. Even if you think it is a clean room, that's not always going to be the case. Your hospital is fairly dirty. The second type of mode of transmission, so you have direct and indirect. Now we have droplet transmission. So droplet is a large respiratory droplet. It's typically greater than like 5 microns. Droplet can travel 3 to 6 feet before it falls. So this is going to be commonly spread by a cough, a sneeze, someone talking, anytime you're doing suctioning on a patient. And such diseases that can be spread through droplet are going to be like your influenza, pertussis, meningitis, RSV. So precautions, if you have somebody that has a droplet type infection, we'll talk a little bit more in an upcoming slide, but typically then you're going to want to be, utilizing the appropriate PPE for droplet. So then you go into airborne transmission. So these particles that are in the air are even tinier. They're typically less than 5 microns. So that means because they're so tiny, they can actually stay suspended in the air for a long period of time. So that is why this is typically, if you look at your PPE, which is going to be coming up here shortly, you are going to have like a respirator instead of just a normal surgical mask. So this can be spread by just breathing, talking, coughing, any type of procedure that aerolizes anything for that patient. Diseases that are spread and they are airborne are going to be your tuberculosis or TB, measles, varicella, chickenpox. So again, precautions They in the hospital will have you'll have to wear a special respirator. So that's like your N95. You'll have to be fitted for that. So you're not going to be able to take care of patients until you have a proper fit test. Any negative pressure room, they will be in. So we will want them in a negative pressure room so that it does not go out into the client hallways. And then we do want to limit that transportation of the patient as much as possible. Again, we'll go over transportation here shortly for anybody that's in isolation. And then you have a vehicle transmission. This is also a common source. So this is when a pathogen is spread through a contaminated source that many people are exposed to. So this, we're not thinking just in the hospital, kind of start thinking a little more broad. So contaminated water. So within a community setting, if there's contaminated water, that's going to be that vehicle for transmission. Certain food. So think about if there is a food, like a food illness, that like food poisoning at a restaurant that is affecting multitude of people. So it's more than just like a blood pressure cuff would have when we're talking about that indirect. Again, medications, if medications are being prepared incorrectly at like a pharmacy or even at that medication plant. There's recently been many recalls on different medications and supplements and all these things. I think recently there was a nasal spray within one of the local pharmacies that it's kind of nationwide. I think it's affecting all of the states because there is a possible contamination in that medication. Again, blood products can be a part of this as well. So diseases that can spread this way are like your hepatitis A, norovirus, food poisoning. And then your last one is going to be vector transmission. So a vector is when a pathogen is spread by an animal or an insect that is carrying that pathogen. So some examples are a mosquito. Mosquitoes can transmit malaria. That's not commonly seen in the United States, but it can be. The Zika virus, West Nile. Your ticks, commonly you're going to think of Lyme disease. Your fleas are going to be your plague. So us as nurses, we need to make sure that we're controlling our environment, we're keeping areas clean, making sure that we educate our patients on insect repellents, protective clothing when they're outside, especially in like the wilderness or where trees are, because you're going to have an increased risk of those ticks. If somebody is traveling out of the country, just giving that education. Many times, if you're going out of the country, um, and you're at risk for malaria because it's spread through mosquitoes, they'll have you actually have like a netted tent over your bed, so like a netting, so that they don't get in while you are sleeping and get you. So then we are going to talk about the number one way to decrease the spread of infection is hand washing. So in multiple of these modes of transmission, hand washing is going to be a huge preventative. So with this, we want to always wash our hands before and after tasks. Um, so the number one way, like I said, is to decrease the risk of infection is hand washing. So making sure that we're utilizing the appropriate steps. Applying 3 to 5 mLs of soap to rub those hands together roughly and robustly, and then rubbing those palms, the back of your hands, between your fingers. And then drying it in the appropriate way as well. So I have lists out here how to wash your hands. Anytime that your hands are visibly soiled, hand sanitizer is not going to cut it. So if you have visibly soiled hands, you need to do soap and water washing. You'll utilize warm water, applying that soap, that 3 to 5 mLs of the soap, and scrub for 20 seconds in all those areas. You want to keep your fingertips down to aid in any removal of your microorganisms, and then you want to dry your hands from your fingers down to your wrists, and then toss, get a new paper towel to turn off that faucet as well. So what is a disease or an infection where I, as a nurse, must wash my hands and not utilize hand sanitizer? So that is going to occur with anybody that has C. diff. So C. diff, you have to utilize a different cleaning in your room. You're going to have to utilize hand washing and not hand sanitizer. That hand sanitizer is not going to clean the C. diff bacteria off of your hands. So you need to make sure that you are actually washing your hands, not utilizing hand sanitizer for C. diff. So what are some other nursing interventions? We talked about some with mode of transmission, and then of course washing hands. So other nursing interventions to stop that spread of infection is making sure that we are educating our patients on covering their nose and mouth when they sneeze, having them do that through or into their like elbow crease. Keep your bedside surfaces clean and dry. Anytime you're going to utilize that bedside table, always making sure that you clean it beforehand. And then always making sure that you change a client's like soiled dressing, soiled linens, anything to help decrease that risk and spread of infection. So this is just a visual example of the 5 moments for hand hygiene. So these are the moments that tells a nurse, us, exactly when hand hygiene is going to be required. Always do it before touching a patient. So anytime you enter the room, knock, knock, hand hygiene. Hi, my name is Faith. I'm going to be your nurse today. Anytime you shake hands, you're moving the patient in bed, taking vitals. Anytime you're about to touch the patient, always wash your hands. Before clean and aseptic procedures, washing your hands, so before starting an IV or preparing an injection, doing a Foley, any type of wound care, and handling any invasive device, we want to always make sure that we are washing our hands, hand sanitizer, doing appropriate hand hygiene. Next, anytime that you have like a body fluid exposure risk, you need to make sure you protect yourself, hand hygiene. So anytime that you've even had gloves on, you remove them, hand hygiene. After caring for a wound or a spill, emptying a Foley, all those times that even that you're thinking, oh, do I really need to wear gloves? Always wear gloves. And then as soon as you remove those gloves, then you are going to perform hand hygiene. Anytime you touch the patient, again, making sure that we are washing our hands, and then even if we are touching patient surroundings, so the bed rail, the IV pump, the bedside table, when we're leaving that room, we are utilizing the appropriate hand hygiene for that patient. Okay, next is your aseptic technique. So first, aseptic technique refers to the practices that reduce or eliminate microorganisms to prevent that infection. So there's really 2 different like quote unquote levels of aseptic technique. So one is going to be your medical asepsis, which is a clean technique. So this is when we are going to reduce the number and spread of microorganisms, ideally, that's the goal. This is going to be utilized in everyday patient care. So this is when we're doing hand hygiene, we're wearing gloves, we're cleaning an environment, we're utilizing, proper disposal of our linens and our sharps. This is when we're going to clean or utilize a clean technique during, basic procedures. So med administration, tube feedings, many of your wound changes, wound cares, that is going to utilize a medical asepsis or a clean technique. So again, those are some examples. This is just really like a generalized approach. Then you have your surgical asepsis. This is your sterile technique. So you guys learned about sterile gloving. So the goal of this is to eliminate all microorganisms, including spores. So we are really making sure that we are quote unquote sterile. It's called a sterile technique. You're going to utilize this for procedures that enter sterile areas of the body. So this is, for example, a central line. You'll be learning how to do a central line dressing change. That has to be sterile. If you think about it, your central line is literally going into the body. And so anytime that anything is going into the body, it's going to be a sterile procedure. Not only central lines, but when you do Foley catheter insertions, again, that is something that is going into the body, and we are putting it into the body, or we're doing anything with it, it needs to be sterile. Um, Certain wound care, again, that's going to be very limited on when you need it to be sterile. If they are in the OR, then yes, you would be utilizing a sterile wound technique. Any OR procedures, those are always done sterilely. Um, and anytime you're handling any sterile surgical instruments, that's not very going to be very common, but just in case you are assisting with like a bedside procedure or something like that, it needs to be sterile. So this is some drainage appearance guidelines. So we're talking about, infection, controlling that, stopping the spread. But we also need to know if we do have like an active infection or a wound, we may have highlighted this and it was in your readings for skin assessment, but we do also need to know this for infection. So with this, you've got, I have 4 images on here. This is from Nurse RN. She is a great online resource as well if you need visual aids. And it has broken down the 4 different types. So first you have serous. That is blood, plasma, low in proteins. So that's going to look pretty clear, pale yellow, maybe thin, watery. It should be odorless. If there is for some reason an odor with this, then we're thinking an infection. Typically, a serous drainage is going to be small amounts. If there is high amounts, then we're looking at maybe this is an infection. So again, if there's odor present at any time or high amounts of drainage, we're looking at a possibility of infection. Sanguinous, that is going to be mainly blood drainage. So this is going to be that bright red, maybe watery and thin initially, but then maybe gradually it's going to darken and thicken over time. If you think about it, it's like trying to clot essentially. So it's going to darken and thicken up. And then you have it should decrease over time, the amount of sanguinous drainage. If for some reason it is increasing, then we do need to notify the provider. Typically, it'll have like a coppery metal smell with it. That's just the smell of blood. If again, it's going to be an abnormal finding if you notice a like a wound or any type of drainage, if that sanguinous drainage increases, or again, there's an odor, we're thinking an infection. Then you have serosanguinous. So this is a mixture of the two. You've got serous and sanguinous. So it's serum and blood. It's usually a light pink color. It should be odorless and should be in small amounts. Typically, as a wound or whatever we are doing heals, it's going to gradually get in a lighter color. So it'll become more serous and not sanguinous. Abnormally, again, if you see large amounts of this, it could be an indicator of infection or poor wound healing. And then if there's any change in the color, so it's starting to turn more sanguinous, or there's an odor, we're concerned about further infection. And then lastly, you have purulent. So this is where you have a mixture of bacteria, dead tissue, fluids, different types of white blood cells. This is what you would typically call like pus, quote unquote. So this is a thick pus-like drainage. It's going to be brown, gray, yellow, maybe even a greeny color, and typically it's going to be odored. It's going to have a smell to it. This is always abnormal. It always going to be abnormal. It's going to indicate an infection. Anytime you have a wound that is purulent, you clean it and then you will do a culture on it. Of course, you would notify the physician, make sure that they have placed an order for culture, and then you'll get that sent off. So next we have switching from what you may see coming out of a wound to kind of what's happening inside of your body. Essentially, you've got normal flora and transient flora. One is normal, one is not so normal. So your normal flora, that is where your microorganisms, these are microorganisms that naturally live on or inside the human body. These are ones that usually will not cause disease. So you're going to see it on skin, in individuals' nose, upper respiratory tract, normal floras within the mouth, GI tract, the vagina, urethra. These normal flora are really protecting the body, providing immune support and metabolism. Metabolism is in the GI tract. It's going to help with digestion. So your gut normal flora helps synthesize vitamin K and certain other vitamins and to help aid in that metabolism. How is it protecting? So your normal flora, like I said, it could be on like your skin, mouth, vagina. It's really going to help compete with any pathogens for nutrients and space. So they say it's quote unquote like a colonization resistant. So it just helps pretty much the good bacteria is booting out that bad bacteria. So some examples, sometimes we do see E. coli in their GI tract, but once it gets into the vagina and into the urinary, pathway, then we're concerned about a UTI. But typically that is found in your GI tract and that is normal. Normal flora, overall, it's beneficial and it's needed under normal conditions. Then you have your non-normal flora, which is called your transient flora. So this is where the microorganism is not normally found in or on the body, and it would typically cause an infection when introduced. So what is transient flora? This is when it's usually can be removed by hand hygiene, but if for some reason hand hygiene wasn't performed, we have a break in that chain that we talked about earlier, then it gives that pathogen the opportunity to be entered into the body. So this, if you think about like C. diff, Pseudomonas aeruginosa, that can happen. Staph infections, that is typically going to be from a transient flora. So then you have your stages of infection. So this is when a pathogen enters the body and infection progresses through these four fairly predictable stages. So as nurses, it's important for us to be able to recognize early symptoms and prevent further spread. So first you have your incubation period. So this is the time between when the pathogen enters and the appearance of the first symptoms. So this, we have no idea, but the pathogen has been entered into our body. We're just functioning pretty normal. The organism at this time, while we have no symptoms, the organism is multiplying. Again, we are feeling pretty good, but we can be contagious even if we have no idea that we have a pathogen incubating in our body. So some examples like the flu can be about a 1 to 4 day incubation period. COVID was 2 to 14 days, so a lot of times that's why you had that 2 weeks at the very initial start of COVID-19, 2 weeks that you had to, stay home essentially. So for us, it's really important that even if we don't think that someone is sick, they're not showing signs, that we're still utilizing hand hygiene. We're utilizing masks and our PPE when needed, and we're isolating when indicated. So just like with your COVID-19 a few years ago, you would have to, if you came into contact, you would have to isolate. Now, not so much. Second is your prodromal phase. So this is your early, pretty non-specific, vague symptoms. So maybe somebody has like a low-grade fever. They're feeling malaise and fatigue, maybe some mild discomfort. They're just kind of feeling off. So this is typically when the patient is the most contagious during this stage. So they're starting to feel some symptoms, something's going on. They haven't hit full-blown acute illness, but they are the most contagious. And then you have your illness stage, or what we would call acute illness stage. So this is when you have full-blown symptoms and signs of this disease. So what's happening, the pathogen is really multiplying rapidly at this point. If you are the one that is sick, the immune system is responding and is active. Now this is when your symptoms really depend on the type of infection. If you have like a high fever, cough, sore throat, now you're having diarrhea, you're having full-blown symptoms. This is when you have that acute illness. This is when you're in this stage. So as a nurse, somebody that's in the hospital in acute illness, that's usually when we would probably see them in the hospital if they do come to the hospital. We're monitoring vitals, we're providing symptom management, we're administering medications. If they need to be in isolation, we're getting them into the appropriate isolation precautions. And then you have convalescence, so or aka recovery stage. So this is your final stage. This is when those symptoms begin to fade. You're probably going to be discharged from the hospital and your body starts to return back to normal. This is when the pathogen is being eliminated or controlled by your body. Your tissue starts to repair anything if needed or if there's any damage. And then typically your strength starts to come back as well because you're feeling better. Sometimes fatigue may persist, and on discharge, making sure that you are still educating your patient, get rest, hydrate, making sure you get proper nutrition. If they are on an antibiotic, always continue that antibiotic. Even if you're starting to feel better, if you still have 3 or 4 days of your antibiotic or however many days, even if it's just one dose, you need to complete that full antibiotic regimen. So then, do I have a systemic, localized, or non-sequomal um, infection going on? So with this, you have a first localized infection. So this is an infection limited to one specific area of the body. Again, it's localized. So your signs and symptoms of a local infection typically like redness, swelling, pain or tenderness to the area, warmth to the area. Maybe we have some drainage there. We have loss of function in that area. So when we think of a localized infection, we're thinking, okay, say someone has a cut or a wound on their foot. Okay, well, that's localized. That's localized to that area. And so if it's not spread or anything, then we would be treating a localized infection. Ear infections are another good one. Otitis media, oral thrush, that's only typically going to be in the mouth. So for us as a nurse, we need to make sure that we are assessing the site. We're monitoring for drainage. We're cleaning the wound if there is a wound. We're treating the pain. We're preventing the spread of any type of systemic infection, so making sure that we're utilizing all of our appropriate hand hygiene. And then if there's antibiotics to be administered, we're administering those or providing education to complete them as well. Then you move on to what we call a systemic infection. So this is infection that spreads throughout the body via like the bloodstream or lymphatic system. This is then a whole body for your signs and symptoms. So now we're saying like fever, there's chills, fatigue, there's an elevated white blood cell count. Maybe they're becoming tachycardic or tachypnea. They're having increased respiratory rate, possibly hypotension if we're thinking of a systemic like sepsis. Are they becoming hypotensive? Is there confusion, altered mental status, especially in our more elderly individuals? Examples of more systemic infections are going to be your sepsis, bacteremia, certain COVID-19 if there's multi-system involvement, polyonephritis that then ends up spreading is going to be more systemic. So anytime something is more spread, it's throughout the entire body. So somebody that is in the hospital for a systemic infection, more common one you would hear of is sepsis. We're going to be monitoring those vitals closely. Depending on how they are doing, they may be in the ICU, especially at first, and then get transferred down to a step-down unit or a lower level of care. Even before they get septic, we want to make sure that we know those early signs of sepsis, which you will be learning in future courses as well. Administering our antibiotics and fluids. We want to always think of our ABCs. So we want to, A is airway, B breathing, C circulation. So we're supporting that airway, especially when they get more of a systemic infection. We're really concerned about potential fatality if we're not treating this appropriately. And so sometimes you may see somebody that comes in pretty severely septic. Well, they're not able to support their airway, so they need to be intubated. And then making sure that they stay hydrated. Then lastly, you have your nosocomial or hospital-acquired infections. So a lot of times you will see them as HAI, a hospital-acquired infection. So this is an infection that develops greater than about 48 hours after hospitalization or healthcare exposure, and it was not present on admission. So a lot of these ones you will hear are like CAUTI, CLABSI, VAP, SSI. So an SSI is a surgical site infection. So they come in, they have surgery, and then they develop an infection at the surgery site. That would be a nosocomial or a hospital-acquired or healthcare-acquired infection. Your VAP or VAP, that is a ventilator-assisted pneumonia. So if they've been on a ventilator and then they get pneumonia afterwards, and they did not show any signs or symptoms beforehand, they had no present illness or sickness or pathogen before then it would be a VAP. A CLABSI, CLABSI, that is central line associated bloodstream infection. So again, they came in, they didn't have a central line, we put a central line in, we did not utilize appropriate sterile technique, an infection or a pathogen was introduced, and now they have a CLABSI. That's just not good. And so we as a hospital, if there is a nosocomial or a hospital-acquired infection that does occur, insurance will not cover the treatment for that. So then the hospital takes full responsibility. And then lastly, it is on here, I forgot to say CAUTI. CAUTI is a catheter-associated UTI. Again, that is when you have a Foley catheter, no proper sterile technique was done, there was a pathogen introduced. So again, how can we as a nurse prevent this? Utilizing appropriate sterile technique when required, timely removal of any lines, drains, things like that, making sure that we are pushing for more independence and not for someone to just keep their catheter in or keep their central line. When can we get those out? As soon as possible. That's safe for the patient. Making sure we're cleaning that environment, utilizing appropriate hand hygiene. These all come in together. So with nosocomial infections, there's like a breakdown of 3 different types. So you have your iatrogenic infection. This is when the infection occurs as a direct result of a medical procedure or treatment. So just always think this is caused by healthcare intervention. So this would be if somebody gets a UTI after improper Foley insertion. So a CAUTI. Say they have a bloodstream infection after a contaminated IV insertion. That would be this type of nosocomial infection. So us as nurses, again, making sure that we utilize sterile and aseptic technique appropriately, following protocols and procedures. And then you have your exogenous infection. This is, if you think exo, it's outside. So this is an infection caused by a microorganism from outside of the patient's body. So this is, a source of our hands. So we give somebody, we don't wash our hands appropriately. We utilize hand sanitizer after caring for someone with C. diff. And we go into the next room and we don't do hand hygiene and we administer oral medications to a patient. Well, we're just now spreading C. diff around. So that would be an exogenous. Or another example is salmonella. And that would be by contaminated food, water, things like that. And then you have your endogenous infection. So this is an infection caused by the patient's own normal flora entering areas of the body where they don't belong. So this is, say you have somebody in the hospital and they get a UTI. Well, a UTI is typically going to be E. coli. E. coli is normal in the GI tract, but once it gets to more the GU tract, then that can cause a UTI. Also, if say we are not cleaning an IV site before we put in an IV, and there's staph on the skin. Well, that staph is pretty essentially a normal flora on the skin, but we did not clean it appropriately, and now we're entering that IV we're literally picking up that staph and now entering it into their bloodstream. So again, making sure we utilize appropriate insertion of like our IV catheters, making sure that we're utilizing good hand hygiene. And here's just a good image of the different personal protective equipment or the PPE that you'll have. So you've got gloves, gown, face shield, masks. Again, there's two different types of masks. If you have an airborne isolation patient, you would be wearing an N95, not just your normal mask, and goggles. And then here is another good visual aid for the different type of infection control, the PPE and isolation precautions that are utilized for the different one. So first you have standards, that's where PPE is required. Typically is only going to be gloves if you're coming into contact with anything. No special rooms needed. This is standard for all patients. So all patients, you assume the infection risk. Next, you have contact. Contact, you need to wear your gown and gloves. Typically, they're going to be in a private room, or if two individuals have the exact same contact isolation pathogen that they need to be in contact for, then they would be in a cohort. You could potentially room two people together. Then next you have a droplet. Droplet, you would then, have to wear a surgical mask. You don't have to do an N95 because remember, droplet, those particles are bigger. They're typically greater than about 5. So this typically private room, you could see it maybe cohort. I've never seen droplet in cohort though, personally. So typically it'll be in a private room here at OSF. Examples of some droplet infection, that's going to be influenza, pertussis, mumps, rubella. Airborne, on the other hand, it is where you need to have your patient in a negative pressure room. There's not going to be a chance that they're going to be in a cohort. Very unlikely unless absolutely deemed necessary. And then you as the nurse will have your N95 respirator mask that fits to you. Examples of this is your TB, measles, varicella. So when we're transporting isolation clients, what do we do? So if you have contact isolation that somebody is in, before we get them out of the room, we need to make sure they have a clean gown and clean sheets on their bed. So we're going to change everything. We are then going to make sure that we are performing hand hygiene and cleaning equipment with appropriate disinfectant wipes. And that's everything. Everything that's going to be leaving the room, we're cleaning and washing down with, again, the appropriate disinfectant wipe. Then when we are done with that, we will remove gloves, gown, perform hand hygiene again before exiting the room. The client will not have to wear any type of like mask because again, this is just a contact isolation. If you have a droplet isolation, you're going to do all the same things as with contact. So making sure the patient has clean gown, clean sheets, performing hand hygiene, cleaning all the equipment with the appropriate disinfection wipe, removing your gloves, gown, perform hand hygiene, and then on top of that, your patient then has to wear an isolation mask. So that is your difference between contact and droplet isolation, like of transporting your isolation clients. Okay, so now we have our concept exemplar. So talking about infection, you will see commonly a urinary tract infection or a UTI. This is an infection anywhere within the urinary system, urethra, bladder, ureters, the kidneys. You do have different types. You may have a lower or upper UTI. It's typically commonly caused by E. coli, which we've said before is coming from that GI tract. Increase in sexual activity, poor hygiene or wiping from the back to the front on our females. Anytime someone is holding their urine, so they have this urinary stasis, or if maybe they're unable to completely empty their bladder, so benign prostate hyperplasia in your males, and then maybe pregnancy in your females. Um, Obviously, catheters, because those can cause a CAUTI, as we discussed. Anybody that is dehydrated, and then postmenopausal women have those hormonal changes, so that can put them at risk as well. So some signs and symptoms, they may have dysuria, which is painful urination, urinary frequency, urgency, the suprapubic discomfort. Their urine may be cloudy or foul smelling. Sometimes you may see hematuria, which is blood in the urine. If they have a more like upper UTI, so we're thinking more polynephritis, they may exhibit a fever, chills, flank pain. So at that costovertebral angle in the back, they would have this tenderness when you do a blunt percussion. They may have nausea, vomiting, malaise. And so those are just things that we need to watch for. Also, one thing is if you do have older adult clients, they may not show those classic defining characteristics and symptoms. They may have acute delirium, confusion. Maybe they're saying they're having new incontinence. They're really having a poor appetite. They're not feeling like eating, or just generalized fatigue. Those are things that then in our elderly population we would want to perform a test to see if they have a UTI. Again, when we're recognizing those cues, we want to collect subjective and objective data. So again, I have an image here with some of those common symptoms of a UTI. When collecting subjective data, we do want to make sure that we get obviously the history of present illness. So what's going on? What are the symptoms that they're having? Any past medical history? Do they have um, chronic UTIs, past surgical history, have they had any type of GEI, GU procedures, certain medications could potentially cause a UTI. If so, what treatments did they have in the past if they do have frequent UTIs? Do they have a family history? What's their lifestyle, specifically like sexual activity? Some cultural, socioeconomic factors will come into play here. What exposures have they had? Allergens, radiation, immunocompromised individuals sometimes are at an increased risk of UTI because their body cannot fight off any pathogens. What are their immunizations? What's their food and fluid look like? Are they more dehydrated? What's their drug and alcohol utilization as well? So just getting that good overall picture with your subjective and objective. Okay, so for diagnostic tests and screening, so typically the first thing we'll do is like a urine test. We'll get a culture and analysis. It's going to be a clean catch most of the time because we want to detect one is if is there an infection going on? And then we'll get that cultured and sent off to really see what type of pathogen is in the urinary tract so that we can treat it appropriately. You could also do serum lab values, so a CBC, a complete blood count. That's going to look at those white blood cells and see how the patient is fighting off the infection. Sometimes you may do a culture and sensitivity. If the patient is inpatient and they have maybe chronic UTIs, do we need to do an evaluation of their nutrition and get dietary involved? Sometimes depending on the pain, especially if we're thinking polynephritis, they may do a sonogram or a CT scan. And then you also have your cystoscopy, which is your surgical procedure. So the biggest thing is with patient education, we want to make sure that we are educating on proper hygiene. So are they appropriately wiping? They should be wiping from front to back. If you have a female, um, that is going to decrease that risk of transporting from your GI to your GU tract, that E. coli. We can educate them on avoiding any type of hygiene spray and appropriate cleaning for their privates. Increase that fluid intake, so making sure that we increase fluids and water specifically, avoiding sugary drinks. One thing that is unique for a UTI is that they can drink cranberry juice. Typically, once somebody does have a UTI, that's not going to be beneficial, but if someone maybe has some reoccurring UTIs, if they drink cranberry juice fairly routinely, then that can actually help decrease that risk of getting UTIs in the future. Making sure that they are performing daily hygiene. If they are on an antibiotic, that they're doing the full course of the antibiotics and not stopping. Making sure we encourage that when they do have to utilize the restroom and void, that they go as soon as they feel that urge, opposed to holding on and retaining that urine. Especially for females, making sure that they wear cotton underclothes. Avoid certain dietary irritants. Some people may have, if they drink a high caffeine or sugar, they are noticing that they're getting UTI. So maybe keeping a food journal if they are having chronic UTIs. And lastly, big one, very important. I've said it multiple times now. This is the second time I'm saying it here. Always complete that full antibiotic therapy. That is huge. It is something that even some healthcare professionals, if you're taking care of a nurse or a physician, you still have to educate them on this, because there are so many times that people will just, I'm feeling better, and they stop taking it. We are just going to create an even bigger concern in the future. Treatment for this is typically going to be an antibiotic. We will treat with a broad spectrum at first until we get the cultures back, and then we will narrow it down to treat the specific pathogen. Sometimes they can take pyridium for pain. That is something you would want to educate the patient on. It will turn their urine orange. Obviously, we would want to manage any pain, possibly do some fluid administrations to keep them hydrated. Nutritional therapy, like I said about that cranberry juice. Typically, as I noted before, it's not, while they actively have one, they can. That's not going to hurt them, but it's really good for a more preventative measure. And then yogurt as well. That gives that like probiotic, and that's going to help with those UTI treatments. So expanding on UTIs, we talked earlier about those nosocomial or healthcare acquired infections. So an example that would correlate with a UTI is the CAUTI, the catheter-associated urinary tract infection. So again, this is a urinary tract infection caused by an indwelling catheter or Foley catheter that's been in place for about greater than or equal to 48 hours on admission. So this is one of the most common healthcare acquired infections that you will see throughout your profession. So this is when that bacteria is going to enter via the catheter from either a contaminated or poor aseptic technique insertion, possibly even through that drainage bag or tubing. That's why it's very important to always make sure that when we are emptying out, that we are putting that clip back on, and then we're putting it back up to the bag and not just leaving it hanging on, possibly hitting the floor. This can also be caused just because of urinary stasis, so that catheter is preventing complete emptying for some reason. There's a multitude of potential reasons. Some risk factors, of course, if they have a indwelling catheter for a long period of time, many times your female sex is going to have an increased risk because they do have a shorter urethra. Of course, poor catheter care, somebody that's immunocompromised, a diabetic, anybody that's really in the ICU and being hospitalized, they're going to be at an increased risk, and your older individuals. So some signs and symptoms going to be fairly much the same as somebody that has a UTI. It's just this is happening in the hospital now. Again, diagnostics, we're going to be doing the same thing: urinalysis, urine culture, CBC. Treatment, ideally, if we can, will be removing that catheter on top of doing antibiotics. So, us as a nurse, what can we do to avoid this? We would like to not even have to put a catheter in. So if we have somebody that, we're considering putting a Foley catheter in, how about we establish a toileting schedule? Get them on a more routine schedule, increasing their fluid intake, avoiding any type of irritants. Always, number one is going to be avoiding indwelling catheters as a whole. If somebody comes in and they don't have any cotton undergarments, we can always provide them those as well. And then we can always utilize a heating pad that may help um, with any pain that they're having. And then we obviously always want to do appropriate hygiene. All right, and that is our presentation on infection. If you have any questions, please let me know.